What is an internal hernia? Right, it is again protrusion of bowel or viscera through acquired or a congenital defect or a fossa or a recess. Generally, all these fossae and recesses are there in the peritoneum or mesentery, and they go into another compartment within the abdominal or the pelvic cavity. So the protrusion is into another compartment. That's the difference about external versus internal. But clinician cannot see this hernia. Like actually in pelvic hernias are also often clinically occult. These internal hernias are clinically occult. This can happen. The presentation is very variable. It could go into this. It could go into this fossa. It could come out. Could reduce spontaneously. Patient could have discomfort. Often we make a diagnosis when the patient presents with a small bowel obstruction. Let this diagram not phase you saying, oh God, there's so many of them. How am I going to remember? It's definitely not as bad as it seems. If you think of all the peritoneal folds and coverings that you already know it all. You know the falciform, you know the lesser omentum, you know the greater omentum coming out from the greater curvature, that's the transverse mesocolon, right? You have the mesentery, you have the sigmoid mesocolon, and then when you go into the pelvis, you have the support rod ligament, then you have some pouches. So if you think through any of these peritoneal reflections or attachments, you could have an internal hernia. So that will simplify, mentally simplify without you having to mug up this list. And then try and see, how do I diagnose internal hernia? So we'll have an overall feature of internal hernia. Then we will try and see some specific key features of each and every one of them. So CT features of internal hernia, look for closed loop obstruction, where you have obstruction at 2 points in the bowel, right? So all internal hernias present generally with a closed loop obstruction. That is why the risk of strangulation and the mortality associated with the internal hernia is much higher than just an ordinary small bowel obstruction due to a neoplasm in the ileum or in the large bowel. Okay, so that is one point to note. That's why we're worried about this internal hernias. So when there's 2 points of narrowing, think of closed loop obstruction. Now, how do I know that this closed loop obstruction is an internal hernia? So that's our next question. Basically, you'll have a cluster of small bowel loops, okay? And that location will not be normal. So what do you mean by abnormal? We will cover as we go along one for each type. There will always be an associated small bowel obstruction. There are some features associated with closed loop obstruction that I mentioned, but I think I will show you images as we go along so it becomes easier. But the key point to identify an internal hernia would be to see displacement either of a structure or vascular, right? Why did we talk of ischemia? Strangulation is very common in any type of closed loop obstruction. So the question I think somebody had asked earlier was, can you not have closed loop obstruction in volvulus without an internal hernia? Of course, you could have closed loop obstructions in volvulus, and there again, they are more prone for strangulation. What are the changes in strangulation? That itself by itself is a session. So I will just touch upon some important points. One is the changes in the bowel wall. The first thing and the most non-specific thing is the thickening of the bowel wall, almost about 3 millimeters, right? It's not really a specific sign. You could have alternating high and low attenuation due to edema in the bowel. But something that tells you that this could be a bowel wall necrosis or infarction is intramural hemorrhage. So we, by protocol, always do a non-contrast CT before we go on to do a contrast CT. Contrast CT, they do say that arterial phase helps us, like in this case, during the arterial phase, you can see that this is a loop that has not enhanced while the rest of the loops is showing enhancement. The other features are, you could see air in the bowel wall, and you could also see paper-thin bowel wall. But when a loop is very large, significantly dilated, even without infarction, you could get paper-thin bowel wall. So there's always these little twists that we see, which makes actually our daily work more interesting. You can see the shape of that loop. That is what I was trying to see. That is a C shape or a U shape bowel loop. That's whenever you see a C shape or a U shape, before you look at the other features, let your brain remind you, oh, is this a closed loop? And then now, what is the cause of the closed loop? So
Can I
these are
say,
some of the,
yeah, can I say, is there a
yes,
pattern? Is there a pattern to that? Like, firstly, the bowel get hyper enhancing due to hyperemia, then it becomes like
yes, yes,
the wall
yes.
becomes
That's what
thin, paper thin, and then there's a like a pneumatosis, like a tiny,
exactly. So if you
and
go
then
through
it no non-enhancing in the later stages.
yes, so that is the pathogenesis, what happens actually in when you say ischemia. So in an initial phase, it could be just venous obstruction, right? So the wall becomes edematous, the pressure increases, it causes capillary stasis, then it increases capillary permeability. We've actually dealt this in the previous case. I've not gone into so much details about what really happened, but there's one interesting thing that happens actually. Intravenous contrast actually can move out of the vascular space into the bowel wall, and the bowel wall can actually remain hyper enhanced. So there are many, depends on the stages of the ischemia that the patient is having. So this is one quick recap. I put in the slides from the previous session. It's actually a closed loop due to just one band. This is an we had given positive contrast into a sigmoid colon. That's how we can differentiate this from the rest. We generally do not give oral contrast. So there was a band from the sigmoid to the ileum. So it's an iliasigmoid band which caused the twist. Now you can see these radially arranged bowel loops. It's like a balloon on a string. You see these mesenteric vessels coming from the loops, so it's literally like a balloon on a string. And then you can see these C shape, depending on the plane in which we are imaging, or the U-shaped bowel loops. So that there, and then all the bowel wall features like pneumatosis and paper thin or intramurally you're going to look for. Next, you look at all the mesenteric vessels. They may be engorged. They can point to the hernial orifice. They can point to the point of twist also. You can see them twisted. Then you can see that particular mesentery, the loop with the mesentery that's involved, also has a little bit of fluid, and that is more edematous than the rest of the abdominal cavity. So they all direct your attention to the area that was twisted and gone into a closed loop. The other findings in this case is not air in the portovenous system, but you're seeing thrombus in the mesenteric vein. So there are some of the quick pictures to show you an idea of how a closed loop is gonna look. Now, I think you're all on board. You're sure how a closed loop looks. I think you're sure how to pick up a strangulation versus a non-strangulated hernia. Now, our job is to find out, can we now be very specific in our diagnosis? Can we say, hey, this is left paraduodenal? I'll tell you why it is, because X, Y, Z. This is right. So I want to see whether I can help you guys reach that point without getting frazzled by the list of internal hernias. I think this is one of the areas that I always avoided reading, but it isn't that bad. So now let us start with the commonest, that is our paraduodenal hernia, and the most common paraduodenal hernia, the left paraduodenal hernia. So left paraduodenal hernia, duodenum is retroperitoneal, and the mesenteric attachment starts at the duodenojejunal flexion, right? At these attachment sites is where there are little gaps, and that is where the bowel loop can enter into the retroperitoneum. So this is an image. One look, we don't have to know that this is what type of internal hernia, but we know, hey, it's a cluster of small bowel loops. We have no business to be where they are. There are some clues. In case we did not realize there are clues, you can see that the bowel wall is thickened. This patient should have had small bowel obstruction, and you can see that mesentery is not looking good. Where is this cluster? It is in the left upper quadrant. So your first key, to unlock your internal hernias, key number 1 for LPH is our location. That's the left upper abdomen. That's a no-brainer because we know where the left paraduodenal hernia happens. Another thing that it does is look at the stomach. It pushes the posterior wall of the stomach anteriorly. Okay, so we've got the site, we've got a structure displacement. It's not good enough. Let us also have a vascular key pointer. So that there are these two vessels. These two vessels, that's the inferior mesenteric vein, and that's the left colic artery. is to lie, if you can imagine in 3 dimensions, in the anteromedial part of the fossa. Easy to think of this. This hernia is going posteriorly, right? And these 2 vessels are lying in the anterior and medial wall of the fossa. Okay, so the fossa of Lancet is a gap at the attachment of the mesentery at the ligament of trees. So through this, between and lateral to D3 is where this fossa lies, and through this the jejunal loops herniate into the retroperitoneum. We've got 3 key pointers. The side is the left. We know it's a closed loop obstruction in the left upper quadrant. The jejunal loops. We look for left paraduodenal hernia. We look where the stomach is displaced anteriorly. We look for the vessels which are lying in the medial and anterior wall of the fossa. That is the IMV, inferior mesenteric vein, and the left polycardium. Assuming we are clear with that, let's go to the right paraduodenal hernia. Well, it's not that simple as the left paraduodenal hernia. I have a loop here. Looks like a closed loop. We haven't really shown you both the afferent and the efferent loop, but it's sort of in the right lumbar region. So when you have a hernia in the right lumbar region, there are a couple of possibilities. It could be right paraduodenal, could also be foramen of Winslow. Right? We picked up a closed loop. It could be a band. Agreed. I do not dispute that content, but we want to make sure it's not a foramen of Winslow or it's not a right paraduodenal. So then how do we make that? So it's location of Winslow and paraduodenal sort of in the right upper abdomen. This will lie lateral to the second part of duodenum, which is a retroperitoneal structures. So where is our Waldeus fossa? It lies sort of at the D2, D3 junction. And again, I have 2 vessels. So we have side, which is the lumbar region. We have vessels, that is the SMA and the SMV. They again lie in the anterior and medial edge of the fossa, because the hernia is going to go through that defect into the retroperitoneum, right? So our vessel, the SMA and the SMV, can be in the anterior edge of the fossa, right? And one more pointer is this. Winslow is this paraduodenal. If there is transverse colon displacement anteriorly, that actually goes more in favor of right paraduodenal hernia. And I also wanted you to know it because if hernia goes into the retroperitoneum, you could also have mass effect or displacement of the ureter. Okay, though it is very rare to cause compression. It's not really mentioned as one of the causes of hydronephrosis. This can be associated with non-rotation, so look for the position of the SMA and the SMV. So when it is in the right lumbar region, think of a right paraduodenal hernia. If there is mass effect, anterior displacement of the transverse colon, it is likely that it is a right paraduodenal hernia, which could displace the D2 medially. Okay, I hope I'm clear with that. With that, we will come to foramen of Winslow. Basically, it sounds very simple. So I thought we really shouldn't get confused with this and the right paraduodenal. But because it's a communication between the lesser sac and the greater sac, apparently it could be misleading. I think I also haven't seen many foramen of Winslow hernias in our practice. One big clue, it was in the liver hilum. So this does not show you a hernia. I've just shown you normal structures. This lies in the hilum of the liver between the portal vein and the inferior vena cava. So that is the foramen of Winslow. So often you will see a beak sign or a narrowing or tapering of the bowel loop at the foramen of Winslow. Again, our vascular displacement is a clue to most of these diagnoses. Portal vein gets displaced anteriorly and the inferior vena cava gets displaced posteriorly. Okay, if this is causing more transverse colon displacement, probably we should go more in favor of right paraduodenal hernia. Depending on the site, also pay attention to the content. It could also include gallbladder, colon. I thought we'll jump from up there, the commonest hernias, to the sigmoid mesocolon related hernias. There are again types and subtypes. You have to be very particular about them. It is a bit tricky to be sure whether it's inter or intra or transmesosigmoid type. But one thing to find out, if you have a cluster of loop in the left lower quadrant, that lies posterior and lateral to the sigmoid, pushing the sigmoid anteriorly and splaying the sigmoid vessels over it. Then we should consider a sigmoid mesocolon related. So I think that sounds simple. So through this mesocolon, small bowel loops pass posteriorly, and then they displace the sigmoid colon anteriorly and medially. You may see these sigmoid vessels sort of draped around that hernia. So again, the clue is our displacement. First, picking up the closed loop location is the left iliac fossa, and then displacement of the sigmoid anteriorly and medially will hopefully be the key that will help you unlock this internal hernia. Perivesical hernia, another favorite site, because there are a lot of recesses. There are laterocecal recesses, there are gutters, there are failure of fusion of the mesentery at the ileocecal junction. All these predisposes to perivesical hernia. The percentages are very low to begin with. So they're all a couple of percentages. But if you see that there is a closed loop somewhere in the right paracolic gutter, the closed loops might be lying lateral to the cecum. Okay, cecum may share the mesentery from the distal ileum, and that would cause displacement of the cecum and the appendix medially. So a location, a cluster of loops there displacing the cecum medially should make you sort of think of the possibility of a pericecal. So I've got a policeman because omentum is the policeman of the abdomen. It's the anterior structure. But suppose if you see a cluster of bowel loops lying as the anterior most structure, okay, then let us consider a transomental hernia. Again, transomental hernias can also be congenital or acquired. Omental defects can be very large, and they may not present with obstruction at all, or they could be small, but often they are seen in the inferior part of the omentum near the free edge. What you really see is that you see all the omental vessels are sort of draped around or pushed around the hernia orifice, and you will see this cluster of loops which are taking the mesenteric vessels along with them. So that would be a transomental hernia. So with that, we are done with the abdominal internal hernias. In case you are confused, I again want to say, one moment you know that it's a closed loop, look for complications of closed loop like strangulation or just reversible ischemia. That will tell the surgeon that this patient needs to go to surgery, right? Then go one step further and see whether it would fit into any of the classical structures, classical types that we have seen by virtue of displacement of maybe the stomach or colon or SME, SMV, IMV, colic vessels. There is this group of pelvic internal hernias. Again, don't get frazzled by these so complex sounding lecture. It really isn't. You know that the peritoneum dips anterior to the bladder. That's a reflection, but that could form a pouch, right? So if you have herniation into that, big enough to cause displacement of the bladder, that becomes a supravesical internal hernia. So where does that lie? That could lie, that is the median umbilical ligament, and you will also have the right and left umbilical ligament. So it will lie in between that triangle somewhere, which is called the supravesical fossa. Okay, the center is the median umbilical ligament, and on the sides you have the right and left medial or the right and left umbilical ligaments. What does it displace? It pushes the bladder posteriorly, or if it's more on the right or the left, it will push it to the right or the left. So your key is the bladder displacement. And obviously there'll be a cluster of groups there. They do not often present with strangulation, unlike a broad ligament internal hernia, where this can present with strangulation. Here again, it's a cluster of loops in the pelvis. In one of the adnexals, one side of the uterus. And if you see, it will displace the uterus and the ovaries away from each other, and the rectum gets pushed posteriorly and away from the uterus gets pushed anteriorly, ovaries are pushed laterally, rectum gets pushed posteriorly and up to the opposite side. So once you can get that kind of, think of that possibility of broad ligament hernia. There is a fenestral type, there are pouch types. I think that just makes it sound too complicated. A cluster of loops in the pelvis in a female patient with displacement of uterus and ovaries away from each other, rectum posteriorly and away from the sac. think of the possibility of a broad ligament internal.